Good afternoon. Let's make this quick so you guys can get to your break and snack. I'm here to talk to you about the deficiency of adenosine deaminase 2, or DADA2, and our treatment triumphs and struggles. But in order to really do that, for those of you who have not seen this disease before or know a lot about it, we first published it back in 2014 in the New England Journal of Medicine, and our cohort here at the NIH was a cohort of children who had early onset strokes and vasculopathy, and then there was some colleagues over in Israel who also published in the same issue about patients they had with DADA2 who had more of a polyarteritis nodosa presentation. And so there's two ways to make the diagnosis. One is you can test for mutations in the ADA2 gene, and you would look for 2 because it is an autosomal recessive disease. But because sometimes genetic testing is hard to get, and actually this is quite easy to get because you can send it to people throughout the world, is you can test for the enzyme activity. And what you're looking for is for patients to have nice and low to absent ADA2 enzyme activity compared to carriers and wild type. We're not going to talk much about this, but we don't know everything about how DADA2 happens, but we do know that ADA2, when it is present, works as a growth factor for endothelial cells. So when you're lacking it, you have disruption in the blood vessels of these endothelial cells. And when you have ADA2, you also promote development of the anti-inflammatory M2 macrophage, but take it away and they're skewing towards the inflammatory M1 macrophage. Take the inflammatory TNF that's released from these macrophages, couple it with a weak vessel, and boom, there you have it, DADA2. But what we first published, we have now seen that there's great phenotypic variability. We do have the inflammatory vascular features, which are listed there, but then there's another subset of patients who will have hematologic features, such as pure red cell aplasia, cytopenias, and trilineage bone marrow failure. And there can also be immunologic patients, too, who have a variety of immune deficiencies or autoantibodies. But it's not so simple because you do have significant overlap between the varying phenotypes to where you can have people who are very inflammatory but also have bone marrow issues as well. So the ischemic strokes that are seen are in very small vessels. We refer to those as lacunar strokes. And there's really no genotype-phenotype prediction for any of the features of this disease. So we don't know who is at risk. But what you can see here is you have a caudate stroke, and then you have a midbrain stroke and a corpus callosum stroke. And these are very common locations that we see strokes in our patients. Patients with this disease also have an increased risk for hemorrhagic strokes, and these can happen spontaneously in a patient who has no history of ischemic stroke or isn't on any sort of anticoagulation or antiplatelet drugs. So we really advocate that these patients shouldn't be put on any sort of blood thinner because if they already have a baseline risk, we worry that couple that with blood thinner and their risk will go up markedly. So here are some of the clinical features. You have livido-racemosa, you have cutaneous vasculitis, ulcers, peripheral vascular disease that you can see there. And actually this is what we see, is that the small vessels in the hand actually are pretty much obliterated in this patient. As you can see down here, you lose, I look at it like a ghost hand, it disappears. This is what normal should look like. And this young man has subsequently had a couple digits partially amputated. That just lists some of the immune abnormalities, which I'm not going to really go over. And as I mentioned before, there's a variety of hematologic findings as well. So when our cohort first came to us, we looked at what their prior treatments had been. And they had been on so many different medications, and they had stroked on any and all of these and any combination of them. So they were not stroke protective. I have thalidomide down here because over in Italy, they had a cohort that they had treated with thalidomide, and they had pretty good response to it, except for the neurotoxicity developed in 4 of the 7 patients who had been taking it. So I don't completely take thalidomide off of the potential treatment board, but we all know the risks that come with that as well. So because our patients have been on everything, we initially opted to go with anti-TNF agents. And here is what we have found. We published this just a few months ago in the New England Journal, is that pre-anti-TNF initiation over the course of 2,077 patient months, our cohort of 15 stroke patients at that time had a total of 55 strokes. And then 733 patient months went by after the initiation of anti-TNF, and during that time we saw absolutely no strokes. Similarly, if you went back and did statistical analysis a different way, you can see that in 733 patient months before anti-TNF was added, there were 37 strokes and none in the 733 after. And what else does anti-TNF help in this disease? Well, the inflammatory and vascular features are primarily eradicated. We do have patients who have lymphadenopathy and fever breakthroughs and patients who have persistent neutropenia. But we do find that our patients came to us initially on a lot of glucocorticoids. And after the initiation of anti-TNF, we were able to wean the first 9 patients out of the 15 who were on it down to 0. Growth and development on anti-TNF. Here we have June 2013. That's when anti-TNF was initiated. Here we have 3.5 years later, and you can see that she has really lost the cushioning facies. She's had marked catch-up growth going to the height and weight, and her prednisone dose was down to none. So patients can have hepatomegaly, and again, when we looked at the patients in the New England Journal article that was published earlier this year, we found that pre-anti-TNF, there were 5 patients who had hepatomegaly and 10 that didn't. And as you can see post, all of the patients who had hepatomegaly had it resolved, and only 2 of the 10 developed it. So it works fairly effectively for hepatomegaly. Similarly with splenomegaly, we're going to look at the same type of figure here. And in the 6 patients who had it, 3 of them on anti-TNF went to having a normal size spleen, and only 1 of the 9 who didn't have it developed it. So again, fairly effective. This is just another way of measuring liver disease, which kind of supports what we were talking about in the prior slide, is that there can be some improvement in the stiffness of the liver measurements. There you can see this is a splenomegaly that got much better. She kind of grew into her spleen. Subjectively, the libido can get better, but as you can see in this patient, this is over the course of 4 years, this was at the time of initiation, she does have persistent libido, so that does not completely go away. And the peripheral vascular disease is not a great success thus far. We do have continued progression of it in some of our patients, and I don't know if it's just because they were started too late and the damage was already done, or if we truly aren't going to be able to prevent the progression of peripheral vascular disease in this disease. As I said, the inflammatory burden went down markedly in our patients. And hematologically, most of them have a nice response. An anemia of chronic disease will obviously improve. If they have thrombocytosis because they were inflamed, that improves. But I do want to note that these stars right here are representing a patient who, after being on anti-TNF agents for a few years, developed tri-lineage bone marrow failure and needed to go to transplant. So hematologically, we're going to talk about that now. It doesn't necessarily protect from that, nor can it rescue people all the time from their hematologic manifestations of disease. The neutropenia is an immune-based neutropenia, and you can see that on anti-TNF, it was not all that effective at bringing patients out of neutropenia, as 7 persisted and 3 actually progressed. So let's just do a summary, because that was a lot of data there. The clear benefits to anti-TNF is the ischemic stroke risk reduction, the inflammatory burden, the cutaneous manifestations of disease aside from lipido-racemosa, and the fibroscans done of the liver. There's very little or no effect to the patients who are transfusion dependent with red cell aplasia. Occasionally it will get better, but more often than not it will not, and the vasculopathy, as I showed you in those pictures. And then the variable effect you could, as we saw, was with the liver, the spleen, the neutrophils, and the immune deficiency. So what about ADA2 replacement? Well, we actually did do a fresh frozen plasma trial here, knowing that there is ADA2 measurable in FFP, and we had patients get 5 days of FFP infusions. And although it was well tolerated, it had a very, very low half-life. Here you would see each day the blue is what their level was before the infusion. And so although it would go up, you can see by the next day it would go back to its very, very low level. And then transplant. So there was a publication by Hassan Hashem and Isabel Metz in 2017 where they looked at 14 DADA2 patients who were transplanted. The clinical indications were pure red cell aplasia, thrombocytopenia, neutropenia, and or immunodeficiency. They used both myeloablative and reduced intensity conditioning, but the approaches were not standardized because these were all throughout the world. And the 14 patients required a total of 20 transplants, and they had 100% survival. My question when reading this, though, was why did it take 20 transplants? And when you looked, 2 of them were errantly transplanted with an affected sibling. They just didn't realize the sibling was affected. 2 of them required boost because they didn't get a sufficient stem cell dose in their first, and 1 had graft failure because he had neutropenia pre-transplant. So let me just tell you a little about our cohort's transplant experience. We've had 6 of our patients undergo transplant now. 1 patient had trilineage marrow failure. I showed you his declining counts in the graphs. We've had 4 transplanted for immune-mediated neutropenia, and 1 who had a combination of pure red cell aplasia and neutropenia. And what I can tell you is 3 had successful engraftment and are doing well after 1 transplant. We've had 2 who required a second transplant due to graft failure, and there's 1 who has required 3. And all 3 of those patients had neutropenia. So it's seeming we do not have it figured out yet, the correct transplanting regimen. It's not just here. Our patients were not all transplanted here. 4 were, 2 were not. And so it's not, I do not recommend just pushing someone who doesn't absolutely need it to transplant yet because we don't have the regimen figured out. Give us a little time and perhaps that will be a better option. Like I said back at the beginning, we strongly encourage you to avoid putting these patients on anticoagulation or antiplatelet agents, although there can be occasional exceptions. And I'll give you 2 examples. We have a 50-something-year-old male with atrial fibrillation who we felt that the risk of him maybe having a clot go to the brain because of that outweighed not being on anticoagulation. And then there's also been a patient who has antiphospholipid antibody syndrome that Boyle takes care of, who also had a DVT, who clearly needs to be anticoagulated. So we strongly discourage it, but there are some outlying cases. So future directions for this disease and for the patients, well, we need to get a better understanding of disease pathogenesis because we really don't have ideas yet of how the pure red cell aplasia comes to be. We're obviously not being able to transplant these immune-mediated neutropenia patients successfully all the time yet. We also just don't fully understand the little we do know. So we need the improved transplant regimens. There is gene therapy development ongoing. That will take at least 5 more years before it might be ready to launch. And maybe as we strive to understand more, we'll be able to find alternative medications. We've come very, very far since 2014 when we had this initial publication, but we still have lots of space to go. This is my team, and we have a big core consultant team that sees all these patients here. We have 53 in our cohort as of next week, and of course the lab too. And Dr. Kastner, it wouldn't be possible without him. So thank you very much. I hope I didn't go too fast, and now you guys can get ready to go to your break.